So first, I apologize for not focusing on fibrolysis in my talk. This work was done by Kyota Tatsuta, from PhD students from surgery, but I hope you find this visualization method for investigating the spatial and temporal dynamics of disease progression interesting. Here, I introduce the relationship between mucosal microthrombus and inflammatory bowel disease. Ulcerative colitis (UC) is a chronic relapsing inflammatory disease of the gastrointestinal tract. UC is known as multifactorial pathogenesis, including genetic and environmental factors. Such factors initially disrupt the mucous layer, an essential component for protecting the surface of the colon crypt at the early stages of colitis. Once the epithelium is damaged, it leads to the loss of epithelium, and impaired barrier function trigger immune cell activation, resulting in chronic inflammation, which is observed on endoscopy as erosive and ulcerative lesions. Various medications have been developed to suppress immune and inflammatory responses in UC. However, these treatments have not been sufficient to maintain remission. In exploring other potential interventions, we consider investigating the pathophysiology during the early stages of UC. Here, we focused on visualizing the mucous layer and mucosal vessels to investigate the pathophysiology in the early stages of colitis. Dextran sulfate sodium (DSS) treated colitis is widely used for the ulcerative colitis model. We added 5% DSS to the drinking water and monitored the mice for 5 days. Body weight started to decrease on day 4, and the disease activity index, consisting of body weight loss, stool consistency, and intestinal bleeding, gradually increased. On day 5, after DSS induction, total colon length decreased, and histopathological analysis exhibited some erosive lesions shown as black arrowhead. Using this model mouse, we directly visualized intestinal regions through minimally invasive techniques, employing agarose fixation to stabilize the intestines during observations with 2-photon microscopy. After injecting red fluorescent tryptc-dextran into the intestinal tract, as you can see, tryptc fluorescence in the lumen and green crypt structure are clearly detected. In control, no red fluorescence was observed in the colonic crypts. In contrast, DSS treatment showed increased red fluorescence in the colonic crypts due to the penetration from the intestinal lumen, indicating that it induces the disruption of the functional mucous layer covering the epithelium. We can also observe the microvessels in the mucosal and submucosal areas. These movies were captured focusing on microvasculature. DSS treatment also showed several microthrombi detected along with the anti-von Willebrand factor (VWF) antibody staining. The presence of mucosal microthrombi has been previously examined through histological analysis using rectal biopsies from patients with UC. However, the relationship between the thrombi form in microvessels and disease severity remains controversial. One key enzyme, ADAMTS13, is critical in maintaining microcirculation by cleaving ultra-large VWF monomers secreted from vascular endothelial cells. In patients with UC, Low ADAMTS13 levels combined with elevated VWF were associated with an increased risk of thrombosis. Additionally, research using DSS-treated ADAMTS13 deficient mice showed VWF-rich thrombus formation in submucosal vessels as revealed by histological analysis and exacerbated colitis. So, based on these previous studies, we hypothesized that microthrombi in the mucosal vessels could affect UC exacerbation, which can be assessed through intravital microscopic analysis. First, we compared colitis symptoms and lesions between wild-type and ADAMTS13 knockout mice. The decrease in body weight was similar, but the disease activity index increased more in ADAMTS13 knockout than in wild-type mice, mainly due to the increase in bloody stool. There was no significant difference in the total colon length on day 5 after DSS treatment between both types of mice. However, the histochemical staining had more erosive lesions in ADAMTS13 knockout than in the wild-type mice. These results were consistent with a previous study that ADAMTS13 knockout worsened the experimental colitis. Next, we evaluated the mucus layer function using the tryptophan-dextran penetration method. DSS-induced colitis increased the red fluorescence in the colonic crypt. We measured the red and green fluorescence inside the crypts daily and normalized the red fluorescence by dividing the green. ADAMTS13 knockout significantly increased red dextran intensity on days 3 and 4 in both the lower and upper one-third sections, compared to the wild type, suggesting that the lack of ADAMTS13 showed early dysfunction of the mucus layer. What mechanisms contribute to the early dysfunction of the mucus layer in ADAMTS13 knockout mice? Then we examined the thrombi formed in the mucosal and submucosal microvessels, considering the differences in ADAMTS13 activity. We captured images over a broad area at the crypt regions and analyzed the number and length of thrombi in the microvessels. Compared to wild-type, ADAMTS13 knockout mice showed a greater number and length of microthrombi from the early phases, indicating that ADAMTS13 deficiency promoted thrombus formation. We conducted further analysis to clarify the significant role of thrombus formation due to endothelial stimulation in the progression of epithelial damage. We analyzed thrombus growth at different locations. Area 1 is located near the crypt, where vessels had a diameter of less than 40 micrometers. Area 3 is a submucosal region, and 2 is intermediate between 1 and 3. Larger vessels, more significant than a diameter of 40 micrometers, were located in the submucosal region, area 3. We used this location's definition to analyze the thrombus. Microthrombi measuring the size of less than 10 micrometers in width were constantly observed after days 3 to 5 of DSS treatment in area 1 near the crypt. Larger thrombi obviously increased over time. Similar changes were found in area 2. In contrast, thrombus formation was less pronounced in area 3. Therefore, the growth of microthrombi near the crypt seems influenced by DSS-induced crypt damage. The growth of thrombi can disturb local blood flow, leading to chronic mucosal microcirculation disorder. We defined the stenosis rate of vessels by calculating the ratio of thrombus width to vessel diameter and classified less or more than 70%. The number of microthrombi regardless of stenosis rate increased over time in Area 1, but no increase was observed in Area 3, indicating that the microcirculation disorder in Area 1 may impact damage in the crypts. Finally, we evaluated the effect of recombinant human adamantium-13 on DSS-induced colitis. Daily intravenous administration of recombinant adamantium-13 ameliorate body weight loss, disease activity of colitis, and histological findings on mucosal erosion in both types of mice. Recombinant adamantium-13 also reduced microthrombi in knockout mice, especially near crypts, and nearly eliminated obstructive thrombi, suggesting that recombinant adamantium-13 has the potential to improve UC. Here is a summary. Mucus layer dysfunction and microvessel thrombus in the DSS-induced colitis model were visualized. Lack of adamantium-13 activity promoted thrombus formation in the damaged mucosal microvessels, especially near the crypt, which disturbed blood flow and exacerbated colitis. Maintaining microcirculation at the mucosal region in the early stages may help reduce colitis activity. I also emphasize that the imaging technique eliminates unexplored spatial and temporal dynamics of physiological reactions and disease progression. Our lab member, Ipei Makita, will present the different dynamics of thrombus induced by the ferric chloride application and needle puncture at the poster section. Please visit and ask him for details. Thank you very much.